Hello, everyone. My name is Matt Sham from the University of Washington. It's a pleasure to be here today. Co-moderating with me today is Rick Avila from Acumetra, and our panelists will include Drs. Zhang, Kandwala, and Rapaka, and I'll introduce them individually in the coming slides. So welcome to session 5, which is our session on overcoming technological barriers in coronary calcium scoring during lung screening CT. Just a brief overview, lung screening CT can detect and quantify coronary artery calcification, which can predict the risk of future cardiac events in currently asymptomatic subjects. However, there are some technical and technological barriers to the acquisition of coronary artery calcification scores from lung screening CT. And ensuring the validity, reproducibility, and accuracy of calcium scores can be challenging in the non-gated, low radiation dose, and high image noise environment of lung screening CT. Just to demonstrate that, I'm going to show you now a CT scan from lung screening, which shows calcification in this patient's left main and left anterior descending artery, demarcated by these arrows. As you can see, this is a very low radiation dose scan. It's 0.6 millisieverts. Many of the standard chest CTs are around 2 millisieverts, so this is probably a third of that or even less. When we perform calcium scoring, what we essentially do is we measure all the pixels in the coronary arteries that are greater than 130 Hounsfield units. So if we switch to that calcium scoring mode, what we'll notice is that the coronary arteries indeed measure more than 130 Hounsfield units, but so does the noise. You'll notice these muscles have a lot of yellow pixels. These cardiac chambers and vessel lumen have a lot of yellow pixels. That means these are all areas of image noise that are measuring more than 130 Hounsfield units. This can be very challenging for a lot of software packages because if they're trying to use the 130 Hounsfield unit threshold to detect and quantify calcification, you can imagine that you might end up with a situation like this where you have a left anterior descending artery. There's a little yellow dot, a yellow pixel in there, which means that measures more than 130 Hounsfield units. And so the question now is that truly calcification or is that just image noise like the rest of the CT scan? And again, we're encountering a lot of noise because of the low radiation dose, and the noise is even higher with patients with larger body habitus, larger body surface area. So if I continue to scroll down, I'll notice another area here in the left anterior descending artery. Is this a patient with 0 calcium score, or is this a patient with a little bit of calcium in that area? Very hard to tell. So if we scroll more, same thing for the right coronary artery. It's hard to tell when something's just noise or truly calcification. Same thing down here. So this is a slide that I've shown earlier. It basically categorizes the different levels of severity for coronary artery calcium, and each category is associated with a risk of future cardiac event and the treatment recommendation. So we draw the line here where a patient either has 0 calcium score, which does not need any treatment, or the patient has a score of 1 or greater, which will require some kind of treatment. So this is where we draw the line. Now, when it comes to calcium scoring during the lung screening, high noise, low dose environment, it's very easy to detect these areas of severe and high quantity calcifications. However, when it comes to low amount of calcification or 0 calcification, it might be a little bit more challenging to distinguish between these two, especially when someone has a calcium score of less than 10 versus a calcium score of 0. And that's particularly tricky because, as you might recall, this is where we draw the line between not treating someone versus treating someone. And so if we're not certain of where this line is really drawn during screening, it can be a challenge. Here's another scan, another lung screening scan. This one performed at 0.45 millisievert, even lower than the previous. And you can see again, there's quite a lot of noise. Some areas of calcification are obvious because they're much larger. They're more than just a single pixel. Same here for the circumflex. But then again, you might encounter these small areas, and it's possible that these small areas are the only areas that the patient might have. This person happens to have a high calcium score, but in patients with a 0 or low calcium score, these are the only calcifications that we might see. And we need to be able to draw the line and distinguish whether this is truly a 0 calcium score or someone with a calcium score of 1 to 10. Again, some of the challenges that we encounter, And as we get lower down in the heart, closer to the diaphragm, when the liver starts to attenuate the radiation, we might see even more noise. So this session is going to explore these technical barriers from the perspective of some of the leading software developers in the country who are at the forefront of calcium scoring in non-gated CT. And I'm just going to introduce the speakers here. Our panels include Dr. Rongwoo Jan, who's coming to us from Coronary. He received his medical degree from Yunnan University and his master's degree in biomedical engineering from Asan Medical Center at the University of Ulsan. He now works at Coronary as a clinical researcher using artificial intelligence. Dr. Jang's main interest is the field of chest imaging and the use of artificial intelligence in the mathematical analysis of the human body. Our next panelist is Dr. Nishis Khandwala, who is the co-founder of Bunker Hill Health. It's a healthcare AI company that enables researchers to develop healthcare AI algorithms through the research consortium of 20 plus academic medical centers, including Stanford and UCSF. These algorithms are distributed for clinical use to the largest health systems in the US. One of their algorithms is an incidental coronary artery calcium algorithm developed at Stanford, which outputs an Agassiz score and MESA coronary artery calcium percentile from routine non-gated chest CTs. Bunker Hill has deployed this algorithm at over 100 hospitals, including the Mayo Clinic and Cleveland Clinic. Our last expert panel member is Dr. Saikaran Rapaka, who comes to us from Siemens Healthineers. He is a senior expert in artificial intelligence and machine learning. He works on the development of novel methods for cardiovascular disease characterization and has contributed to the development of multiple AI-based clinical products and research prototypes. He led the technology development for AI-RAD companion chest CT cardiovascular, which assists in the detection and reporting of cardiovascular pathologies such as coronary calcification and aortic dilation on non-ECG-gated chest CT examinations. He's passionate about clinical research collaborations for evaluating AI in clinical settings and has contributed to numerous peer-reviewed publications. And with that, perhaps we can start. So the first question I want to open to our expert panel members is the radiation dose that we currently use for lung cancer screening, which is currently set at 1 millisievert or less. And so the question is 1 millisievert an adequate dose for calcium scoring during lung screening CT, particularly because we're trying to distinguish a calcium score of 0 versus potentially a calcium score of 1 to 10. What are your thoughts on this? And we can go down the list of our panel members, perhaps starting with Dr. Jang. What are your thoughts on this?
Yeah, so I'd like to address that this is like autonomy, but I'd rather say that yes, it is important to distinguish CAC 0 is equal to 0 from CAC more than 1. So it's a very important question. However, I think that our autonomy should be like addressed very like meticulously. So for those issues, we have to the less dose, the more noise is like obvious. However, the optimal threshold should be set, because for the lung cancer screening, the low dose radiation is like acceptable, but for the low dose CT, the CAC finding the CAC very accurately is not like finding long dose very specifically, sensitively. So for the lung cancer screening, we have to find the optimal threshold between those and the the CAC score. So that is my point.
Thank you so much for that. And what about Nish Khandwala? What are your thoughts on this?
Yeah, it's a good question. The algorithm that we are distributing that was built at Stanford, that one performs at a PPV and NPV both in the low 90s, which means that it has a considerable differentiation. It is considerably able to differentiate between a CAC of 0 and a score about 0. What else add on to here is, one, I think we need to perhaps break the bucket of 1 to 99 down even further. What we did was we had obviously a CAC bucket of 0, but also then of 1 to 9 and then 10 to 99, which helps with the further differentiation. And then my final thing on this is, I think it really comes down to what the intended use of such a device is. For example, if the intended use of this device is to opportunistically find patients who are at high risk for coronary artery disease, one option that exists is when the calcium score is detected to be above 0, only then send it to the radiologist or to the patient that, hey, the calcium score is 0, is greater than 0. However, if the calcium score is 0 as detected by the algorithm, do not send any notifications. So do not preclude the patient or recommend that the patient should not get a gated calcium study, since the modality that we are getting this calcium score from is suboptimal compared to a gated study. And so I think there are workflow tools that can sort of workflow dynamics and optimizations that can be made to ensure that when the algorithms performance degrades because you're looking at very small specks of calcium due to the score range, you can make sure that the suboptimal modality does not get in the way of appropriate patient care.
That's an excellent point. Thank you so much. And Dr. Sairopaka?
Thank you. Maybe I'll start with the comment that I think computed tomography as a whole, right, was invented around 1972. And at least from us, the first commercial scanner from Siemens was in 1974, right? And just in terms of like, I find this funny that the first neural network models were actually trained 1958. So computed tomography as a whole is actually younger than artificial intelligence in some sense, right? And it's actually evolving also very rapidly, about as rapidly as even AI is in some ways. If you think about when the lung cancer screening trial imaging was collected, that was 2002 to 2004 with a target of 1.5 millisieverts of dose for the imaging. And NLST is about halfway between 1974 and now. So it's basically the whole world has changed in terms of scanner protocols, in terms of what kind of doses we can get with modern scanners, right? And there's a lot of research, including some that was shown yesterday, that with high pitch acquisitions, with ultra low dose like tin filter kind of acquisitions, you can push the dose down to as low as 0.3 millisieverts and still get full chest coverage, right? These publications have also evaluated, I think, multiple of them, looking at how does the sensitivity and specificity of calcium detection change with these low dose kind of acquisitions. And a lot of them show that you can get basically 95, 96% accuracy in the overall picture. Now, you raised a very good question about the low calcium scores in the 1 to 10 and 10 to 100 kind of a range. The tricky thing about Agatston scoring as an algorithm is that it weighs different pixels differently depending on the intensity. And even in the gated calcium scoring, in a slice, if you have less than 1.05 or something millimeters squared of calcium voxels, right, that lesion is kind of excluded from the scoring, right? Now, we cannot apply the same threshold to chest CT because the pixel sizes are much larger, and there is no as such accepted limit of how many pixels can you exclude as noise or how many pixels do you consider as a lesion. At the 0.6, 0.7 millimeter pixel sizes that we do for chest CT imaging, something like even 5 pixels together, 5 voxels together, right, can already hit a score of 10 for chest CT imaging. And so it becomes then how much noise suppression was done and what kind of protocol was used matters a lot. Which generation of scanner was used kind of matters a lot. I think if you see academic publications, some of the centers which tend to have the best results will also more likely than not be using more recent scanners. And so as the technology evolves and as imaging goes to newer protocols, I feel that we will reach this kind of situation where we are able to address this much better. But I think we are not being ambitious enough here when we say 0.6 to 0.7. I think it can go even lower.
I think those are very good points and absolutely true that even an ECG-gated calcium scan can miss tiny calcifications, and we see that on a regular basis as well. So definitely very true. And I don't think, as you said, there are no guidelines or rules in terms of what threshold of calcium can you exclude or eliminate and consider zero in the setting of lung screening, which is very important. I think that will probably solve many of these situations that we see where we're not sure if it's noise or calcium. I think those can be correctly or equivalently eliminated, just like they're eliminated during a standard ECG-gated scan. Completely agree. I just want to open the floor to Rick Avila in case you had any thoughts or comments on this so far.
I was just asking, hello, can you hear me?
Yep, we can hear you.
Okay, so first of all, why is there such a strong drive to such a low dose? We're not operating in that load with lung cancer screening. So it seems a little excessive. Second point is, we've seen scanners trade off resolution for noise, depending on how low you drive the dose down. So as you push that dose down, you might think you're getting a good deal from the scanner, a good resolution from the scanner, but it might have traded it off. And without calibration, you have no way to know. So I'll just point out that there's a fundamental performance trade-off between resolution and noise at a given dose. And without knowledge of that, you can't really optimize the system.
Absolutely, I completely agree. I think the radiation dose standards were set back in the days when the CT scanners were delivering a lot more radiation, and I think the technology has advanced so much further now that maybe that's not as big an issue, but clearly that definitely needs to be revisited in terms of what dose is adequate or safe enough for patients. So excellent, very excellent, very good points. So moving on to the next slide here. Can artificial intelligence reliably remove image noise without removing calcification? And can the problem be solved without the use of AI or other noise removal technology? So I just want to open the floor again to our panelists, Dr. Jang.
So when I see this reliable removing the noise, I see some kind of accuracy when we do the machine learning analysis. So let's suppose we have like lung screening program that is taken over the general population. Then you will have almost every patient will be very normal patient, and really few patients will be the lung cancer patient. So is the lung cancer reliable? That means if the reliable means accuracy, we can like diagnose all the patients into normal. This kind of situation is same as this question. So when I see the reliable, I see the accuracy. So it is based on the clinical scenario. So if you want to like increase the sensitivity, or if you want to increase the specificity, you can set the clinical scenario differently. So when we do the this kind of screening program, we use the cost effectiveness, right? So if you do the cost effectiveness analysis, and if you think that, oh, I agree with the strategy of treating all the patients, I agree with the strategy with not treating all the low risk patients. So it is based on that technology, and of course, machine learning gives some kind of threshold to segment the coronary artery calcium score. So we can set the optimal threshold based on our clinical strategy, based on whether we will increase the specificity or whether we will increase the sensitivity. That is my point of view.
Those are excellent points. I agree that the accuracy can definitely be adjusted based on whether we want to detect more or we're willing to miss more, depending on what we're after. So excellent points. Dr. Kandwala?
I think that you do have some limitations of the modality. However, how you train and how you validate the AI algorithm goes a long way in addressing this problem. For example, the way we have seen this algorithm get trained and tested was by finding patients who had both a non-gated study as well as a dedicated calcium scoring scan acquired within 6 months of each other. Since the dedicated calcium scoring scan was a gated one, the calcium score, the CAC score on that study was used as a reference standard for training and for validation, which given the modality type, given the gating, and given the nature of a calcium scoring study, you have minimal noise compared to that of a lung cancer study, compared to that of a non-gated study. And so if you train an algorithm to take in a non-gated chest CT, a lung cancer CT as input, and you try to get the algorithm to produce the Agatston score, the CAC score that is comparable to that one for a patient who also got a gated study within 6 months of the non-gated study, then you can account for a lot of the noise, and the algorithm learns to differentiate between what is noise and what is calcium. But again, you can't get a perfect algorithm there. It's going to make mistakes to some extent just because there will be noise, but you can mitigate this problem to a large extent by using gated studies as the reference standard.
Excellent, thank you. I think that's a very good point about the training data set and training the system to whatever you eventually want it to learn about. So excellent point. Dr. Rapaka?
Yeah, so very, very good question. I think as far as noise is concerned, one of the main factors that contributes to noise in CT imaging is low energy photons, right? And from the acquisition point of view, I think the two technologies that help with this, one is tin filtration, where tin selectively it stops all of the low energy photons and it changes the spectra of what is actually going through your sample, getting much better image quality. And on the more recent, the photon counting scanner that Siemens has released, the detector is capable of getting the spectra of the photons. So there is electronic noise suppression automatically where the low energy photons are not included in the image formation process. So you selectively choose only the photons that contribute to the high image signal. With your permission, maybe if I can share my screen for a second.
Sure.
Right. Do you see my screen?
Yeah, we see it.
So here, what I'm showing is this publication from this year, Zook et al., which is comparing basically a reference standard, same set of patients imaged with the 120 kVp standard calcium scoring protocol with the tin filtration, where the average dose with the tin filtration was 0.3 millisievert, I believe, and showing the confusion matrix of how the calcium scores changed for the same set of patients. Now, except in the 1 to 10 range, where you will see a change from 1 to 10 downgraded for a big subset of patients, it's overall pretty consistent in what kind of scores you're getting. Now, the problem with 1 to 10 range, both even for the gated calcium scoring as well as especially for chest CT, is the rescan variability even for the same patients and depending on which kernels you use. Like for the same acquisition, if you use filtered back projection versus model-based iterative reconstruction or a different convolution kernel, there's quite a bit of variability in what score you're getting, simply because the algorithm for computing Agatston score is very sensitive to small changes in HU around that threshold for small calcifications. Then you have the high pitch chest CT versus ECG gated, which was also showed yesterday, showing excellent performance across all of the categories, and a recent publication that is showing a single ECG gated high pitch ultra low dose chest CT to do both lung nodules as well as calcium scoring on the same acquisition, showing very high correlation in the scores, going from very low scores to very high scores. Also getting doses in the 0.3, 0.4 millisieverts for the gated chest CT. So I don't feel noise by itself, even from the physics standpoint, is a very high issue. It can be taken care of. on top of which now there are also AI-based approaches, which both my team as well as many other vendors are actively working on to do AI-based noise suppression.
Excellent. Thank you. Thank you so much for sharing that slide. It's definitely very informative, and I completely agree that the amount of noise that we're seeing is pretty acceptable considering what we're trying to measure and the categories that we have. Thank you so much. I just want to open the floor again to Rick if you have any comments or thoughts.
Yeah, actually, on the lung nodule side of the house, Mario Silva over at University of Parma has worked with Siemens scanners and shown great efficacy of tin filters as well. So I completely agree with Dr. Saikura.
Perfect. So let me just share my slides again here. Moving on to our next question. Oops, sorry. If the slice thickness is reduced from the current TCG-gated CT scans of 2.5 or 3 millimeter down to the lung screening slice thickness of 0.6 millimeter, while keeping radiation dose constant, would it help distinguish these tricky categories of calcification, or do you think it will make it worse? There's always a question of more data might be better, so maybe higher spatial resolution is better. But I wanted to hear your thoughts about this. Maybe we can start with Dr. Jang.
Yes, so please understand my ambiguity of the answer, but I don't want to answer these questions like economy. So for me, it is very important to distinguish CAC equals 0 from CAC bigger than 0. But let's go to the emphysema. So we know that mild emphysema, the early emphysema and prism are hard to like detect, and we can like prevent them from worsening by smoke cessation. But do we do that like very regularly in the daily practice? So comparing to the COPD, I think that CAC has some kind of different aspect because CAC 0 threshold is like determination of the statin treatment, but it's like, do we have to accurately define CAC equals 0 from CAC bigger than 0? So when I see the slice thickness, I see the like there's like this kind of parabola, because if the slice thickness is too much wide, big, then you will have some kind of partial volume effect, and if the slice thickness is very thin, you will have a lot of noise. So I don't think that this kind of question can be answered like yes or no, or one is better than the other. But we have to, as I mentioned in the earlier questions, we have to assume the clinical scenario first. So if we want to distinguish CAC equals 0 from CAC bigger than 0, then we have to assume that this patient will be treated or will not be treated. So that is the like clinical scenario, and we have to determine that first.
I see. Thank you for your thoughts. Yeah, definitely. It could be a sliding scale. We don't know, for example, if 0.6 millimeters optimal. Currently, lung screening is being performed at 1 millimeter slice thickness, but definitely there's room for trying to figure out which slice thickness might be an improvement versus a detriment for calcium scoring. Yep.
Just briefly, when you cut the slice thickness in half, your noise goes up by a factor of radical 2, so square root of 2. So
yep.
So you can use that as a guide, generally speaking, in CT.
Yep. Dr. Conrala?
I think the answer to this is yes and no. Yes, in the sense that there will be the small specks of CAC, which otherwise would have gotten drowned in a larger slice thickness, are now visible with a smaller slice thickness. But then you also have to take into account how these algorithms are trained. there are different ways of training these algorithms. A vast majority of these types of algorithms are not trained on a slice by slice basis, where the algorithm takes in a voxel as input as opposed to a slice as an. And when you get a voxel, you might actually coalesce a couple of slices together, which in this case would just defeat the purpose of having a lower slice thickness. And so if your algorithm wasn't built in a way where it takes things slice by slice and instead coalesces slices to get to a minimal voxel size, in that situation, a smaller slice thickness is not necessarily going to help detect any better. And so, yeah, I think this question would really emphasize the need for a strong collaboration between that of a physician, someone who understands CTs, and then someone who understands machine learning, because you could do everything correctly and with the right intentions from a physician standpoint and from the standpoint of someone who really understands CTs. But if the machine learning engineer does not understand why you made the trade-offs that you did, then the architectures that they might choose for their algorithm, the way they might treat it, might actually just go and negate all the thoughts that you put into the study itself. And so just something to keep in mind.
Thank you for that. I just noticed an insightful comment also from Dr. Ella Kazruni, who's in our audience. He mentions that the ACR practice parameter for lung cancer screening is actually a 2.5 millimeter slice thickness. So that would make it actually identical to the ECG-gated dedicated cardiac calcium score CTs. Although, now that I think about it, if we use 2.5, I have a feeling that many of our lung nodule advocates will frown against that, but we'll see. At many sites I practice, for some reason, they've all done 1 millimeter. I'm not really sure why at different institutions 1 millimeter has been probably the most common slice thickness that I've seen. I don't think I've actually seen any lung screening program do 2.5 for some reason. I'm curious in the audience, has anyone noticed any institution do 2.5 like routinely as their lung screening slice thickness?
Not recommended by QIW. No, it's not recommended by most organizations, most guidelines.
Interesting. Anyway, let's move on to Dr. Opaka for this question again about slice thickness and whether it's going to be helpful versus no help at all.
Yeah, I agree with previous comments also. Definitely reducing the slice thickness. When you have these very small calcifications that are giving scores of like 2, 3, 4, 5, typically their HU value is also very close to the threshold of 130. You're looking at 150, 160 HU, very small calcifications, early stage of disease. And with the really thick slices, this kind of tends to get averaged out, and you see below the 130, and suddenly this thing is outside the threshold of what gets selected for scoring. The thinner slices tend to, for small calcifications, capture its intensity more accurately. But as pointed out previously, I think it also increases a little bit the noise, and it's a trade-off. I think the question is also similar to calcium scoring, where there's a MESA and there's a percentile risk calculator and so on. I think for this relatively high risk population compared to like the routine calcium scoring kind of screening population, I don't know if there's a well accepted kind of a percentile population health risk model that says how many patients in the lung cancer screening program have scores in this 1 to 10 range. And I feel a lot of patients are going to end up with higher scores simply because they're a higher risk group. So I'm not sure exactly capturing the really small calcifications by taking smaller slices, what is the kind of trade-off? Is it worth the effort for the very high-risk population?
Excellent comments. Absolutely. I think one of the challenges in our study of calcification lung screening is that we don't have large databases of ECG-gated calcium scores for the same exact group. In other words, we may have thousands and thousands of lung screening patients, but those same patients may not have an ECG-gated calcium score CT for which we can use as the gold standard to know what exactly is happening, or at least to the best of our technology offers. So,
Maybe
all
if I can just add a disclaimer to keep the lawyers and FDA happy. I think all of the comments I'm making through the whole session are not recommendations, just in the sense of research, right? Like,
right, absolutely.
I'm just an engineer.
Yeah,
I think it doesn't represent Siemens.
Not, definitely not.
very good, excellent. Another question now relating to cutting edge technology. Other than cost, do any of you see a disadvantage to photon counting CT versus the traditional CT scans, given its superior spatial resolution, temporal resolution, and image noise benefits? And for those of you not familiar with this technology, it's the up and coming, or actually the current superior standard CT. And you can see the price range here. We're talking the top end photon counting CTs exceeding $5 million with a much better temporal resolution, meaning it can freeze motion better compared to the more traditional CT scanners that are much less in terms of cost. So any thoughts? I don't know how many of you have experience with photon counting CT or tested your data on it. Dr. Zhang, what are your thoughts?
Actually, I haven't experienced photon counting CT by myself, but I have read some papers and saw some data sets from the photon counting CT. And what I felt is that this can be mind-blowing thing. So when I see photon counting CT, it is a very different physics. It has very different physics, and the image quality is like astonishing. So I saw a paper from radiology assessing that the post-COVID sequelae images, and it was, when I first saw the image, I thought that, so is there any more clinical benefits? But when I come to the mind and I think deeper and deeper, I believe that photon counting CTs can be our next our next step and next modality for the coronary calcium scoring, as well as other very noise specific disease and other clinical scenarios. I believe that.
Thank you so much. So we have one vote for a photon counting CT. What about you, Dr. Kandwala?
I think that we haven't tested this algorithm on photon counting CTs, and with that prior, I think that there will be probably a strong need to retrain algorithms using data from photon counting CTs. In terms of what are we trying to accomplish, like that is a question that would need to be answered here. Like if you are looking at using an algorithm like this to incidentally find patients with a calcium score greater than 100 who might previously not been on statins or but not have visited a cardiologist, adding photon counting CTs doesn't help with that. These algorithms do very good at finding patients with a calcium score that is greater than 100 or higher. So yeah, I think like if don't move to photon counting CTs just to detect CAC better. Like I think that's already accomplished with the current set of CT scans. But in the event that the industry moves towards photon counting CTs for other reasons, these algorithms would need to be retrained for sure.
Very good points. Dr. Zhang has another question, a comment.
Can I add one more sentence?
Sure.
We have to totally retrain our algorithm from the base.
Excellent. So very similar to what Dr. Kandwala had mentioned. So Dr. Apaka, your comments on photon counting CT?
Yeah. I can't comment on the price because, first of all, I have no idea how
Sure.
vendors have priced it. But to be honest, I am not sure of disadvantages. If I really have to push myself to say something, the amount of data it produces tends to be twice as big, simply because matrix size, and also you get, if you want, two different energy thresholds, so you tend to produce more data. From a data scientist perspective, I feel that's a good thing, but I'm not sure from a workflow perspective. Different teams have different expectations.
Excellent. And I also want to comment that yeah, these prices are not from the vendors; these are from just Google searches. So definitely, I can't promise any accuracy for these prices.
Impersonation.
Okay, Rick, any comments about photon counting CT before we move on?
I just want to, I mean, it's a wonderful addition to our ability. The cost, of course, is not going to make it something that is used in most places for a long time, right? So, I think what we've seen in lung screening is that with every advance in resolution and other things, we've gotten, clinicians have made use of that extra information. So I'd be willing to bet that achieving the higher resolutions balancing the noise would ultimately pay off for patients, but you know, that remains to be seen.
Excellent. I completely agree. So for our next question here, one of the concerns with the growing number of software companies that are measuring calcium on non-gated CTs, there's a concern that if a patient gets a score from one institution using a certain software vendor, they go now to a different institution, a different clinic, and get a different score. They don't know if the patient really switched categories, or maybe they're the same category, but the two software packages are just doing it slightly differently. Is there any way for the industry to ensure that the scores from one vendor will not differ greatly from those of another vendor? And we're only talking about categories. Obviously, there might be slight difference in absolute score. You might get an Agatston of 100 versus 110. But in terms of big shifts between one category to another, is there any precedent for competing software vendors to develop a clinical standard together? One example that was already mentioned was, for example, when I don't know if software vendors can decide that if 5 pixels scanned at 0.6 millimeters together should be eliminated as calcium and considered just noise, things like that. I just don't know if there's any precedent for the different software companies to work together to create a standard like this. We'll start with Dr. Jang.
Yes, so in my perspective, I think there will be some discrepancy between CAC equals 0 between the vendors and algorithms, but the majority of the cases which has more CAC score bigger than 0 will not be that clinically significantly different. So and when we see the historical perspective, I think that Augusta score was developed in 1990s, and it was then over 30 years have been validated among a lot of kernels that the CAC equals 0 and CAC score and CAC classification is very useful in determining the future CVD risk assessment. So I think that this historical issue addresses that the vendor difference between AI algorithms of the CAC score is similar to that of the validation of Augusta score among kernels and vendors and other factors. So we will proceed to validate these kind of comparison studies to address this vendor is not that different from that vendor, and that vendor is not different from that other vendor, but there will be a slight difference between Auguston equals CAC equals 0 and bigger than 0. That's my perspective.
Thanks so much. Dr. Kandwala?
I think this should already be the case if you assume that the FDA is doing their job. Because when you ask the FDA to clear an algorithm like this, you are asked to show how you validated the algorithm and the performance metrics across different subgroups, across different buckets. And the criteria that the FDA has for clearing different algorithms is fairly consistent. So if there are 2 or 3 algorithms in this space that are all cleared for producing an Agatston score from a low-dose non-gated chest CT, then those algorithms should agree with each other more. Of course, as you mentioned, you could have a difference between of 10 Agatston units or 15 for a score of 100. But overall, as far as buckets go, they should match. The only caveat here, I would say, is if the vendors, as we know, Agatston scoring, the thresholds of 100, 300, 400, they were based off of gated studies, not non-gated studies. And because of the differences in mean attenuation, a CAC score from a non-gated study using Agatston scoring algorithm was very different from that of a gated study. So as long as the vendors use the same reference standard, which is either just the non-gated study itself or the gated study, in those circumstances, I would imagine that the different vendors' algorithms would agree with each other.
Perfect. Thanks so much. Those are very good points, especially with the FDA role in terms of clearing software. Dr. Rapaka, your comments?
I think I broadly agree with what was said before. With FDA, I'm not quite sure. Actually, there was a simulated study FDA had themselves done with their reviewers, giving all of them the same kind of application, and showed actually significant inter-user variability between how different reviewers within FDA will comment on the same application. So it tends to be evolving field. They're also kind of learning how to regulate this as time goes on. In terms of the calcium score itself, I don't think, I think it's just out of convenience that we use the same definition of even how calcium score is defined on the gated scans, also on the non-gated scans. And there is so much variability even across that, whether you do ordinal scoring or just presence of like none, mild, moderate, severe without actually giving a number, or calcium volume instead of Agatston score, because a lot of providers like primary care physicians would say, what do you even mean by Agatston score when it was never defined on these kind of data sets? By definition, Agatston score is kind of defined on ECG gated data sets. So the word is kind of difficult to use, right? So I think that will still take some time, even defining what should be included, as you mentioned before, what size can be thresholded as noise and so on. I don't think there's an easy answer for this topic, but it'll, as time goes on and as we get more population risk kind of understanding, I'm sure it'll reach a standardization.
Excellent. There's a question from the audience. We actually have a lot more questions for the session, but I think we've answered the bulk of the very interesting questions, and maybe we can start answering some of the questions from the audience here. I'm just going to read some of them here. Let me see. There's a question, how do you, from, I think this is a, I can't see the full name of the person asking the question, I just see initials. How do you deal with the known variability of council unit values at different tube voltages? The applied tube voltage ranges quite a lot, and this must impact considerably the Agatston score. So it's a very good question for some scanners that maybe increase the tube voltage of maybe 140 kV for larger patients. How would you deal with a calcium score in that situation? Anyone from the panel can take that.
Maybe I can take a comment at least on this.
Sure.
So as far as the product is concerned, typically, at least when we do the regulatory clearance or something, we will say KVPs of maybe 100 KVP or more, right? And the because at that range, I think 130 becomes more of a reproducible number that you'll always see calcifications. And the question we are trying to address is not always, at least from an AI perspective, is this the correct score? But the question of if the same image was scored manually versus the same image is scored with AI, do you get the same calcium picked up and the same numeric score that is produced? Now, it's possible that if you do a same patient, one with 100 KVP, one with 120, one with 140, the manual scoring that you do with the semi-automatic tools that are available will give you 3 different numbers. But at least when we validate, what we try to show is with the AI, you get close to the same 3 numbers, not that there's one universal number that you try to get always.
Excellent point. Other panelists want to chime in?
I think this sort of also goes back to how these models are trained. I think in the era of deep learning, it's really whatever data you feed in is how your algorithm performs and is developed. And so if your training data set does not have a spectrum of different KBP values, then your algorithm is not going to be that well performant across the ranges. And so even when you do your subgroup analysis, you're asked by the FDA to break down what amount of your data set had what KBP values, and for each KBP values, how did your algorithm perform? So the honest answer here is that deep learning is a brute force way of doing things. And in this way, the brute force way is just by making sure that your training data set has the entire spectrum of KBP values.
Thanks so much. Perhaps last comments from Dr. Jang. We're right at the end of the hour. So, Dr. Jang.
Yeah, so as mentioned, it is very important to acquire the adequate data set. But if you do not have such kind of data set for the training set, you have to do the modification process, like post-processing process of the results. So it is very important to when we do the chastity analysis, we assume that air is minus 1,000 and water is 0, right? So like that, we have to do the post-processing of the image, like technically, like we have to calculate the myocardium Hounsfield unit, mean Hounsfield, and cardiac chamber Hounsfield unit, and we have to utilize that kind of things to get our data and result be more correct. Yes.
Excellent. Thank you so much. Everyone, I just wanted to thank all our panelists for the excellent insight, all the comments and amazing thought that's put into your responses. I really appreciate it. Any last words from you, Rick Avila?
Yeah, no, I think we covered a lot of really important points. I would say, though, the multidisciplinary approach we took with Kiba on small lung nodules and the use of phantoms and calibration devices to use actual quantitative values for optimizing imaging, I think it's the way to go. And we'll probably start doing that for the triple diseases that we're looking at here for lung screening. So looking forward to working with everyone on that.